I'm not a professor yet, but thank you. All right, so it was with great pleasure that I want to talk about our 2-year outcomes for our first in human study of using amnion epithelial cells in babies. The two speakers before me have eloquently discussed the various risk factors of bronchopulmonary dysplasia, but the set which we are dealing with in this study have severe bronchopulmonary dysplasia, so they are at the highest end of severity. I want to start off by talking about some stem cell for BPD trials. So this is a map of the world from clinicaltrials.gov talking about the current or completed studies on stem cells around the world. As you can see, Europe is missing completely, and most of the studies we have on stem cells for BPD comes from Asia, most importantly from Korea and from China. Today we are going to talk about how the Australians are getting into the picture. Those studies which have been done so far or are completed or ongoing, most of them have worked with mesenchymal stromal cells. Mesenchymal stromal cells can be cultured and harvested from a variety of organs. One of the organs which people have used is umbilical cord blood mesenchymal stromal cells. They've also used placental-derived stromal cells. What we are focusing on is the amnion epithelial cells. So the amnion is a layer of the placenta which is present in every baby, and it is a good source of harvesting these amnion epithelial cells. Amnion itself has been used as a regenerative tissue since the post-World War era for eye injuries soldiers had, and since then it has not been used at all for any indication. So we embarked on this first in human trial with the hope that these amnion tissue, which I'll come to as I talk about the discovery, have regenerative potential. Why do they have regenerative potential? They have regenerative potential because the amnion epithelial cells are cells which are present prior to gastrulation, which means that they can go on to regenerate or help in the regeneration of tissue, whether it's ectoderm, mesoderm or endoderm. So with that knowledge was a big discovery to trial period. The discovery is not my work. It has been work from my scientist colleagues at the Monash University and Hudson Institute. But I got involved in 2011 when we started to have discussions around moving these therapies into the clinic. If you are interested in reading in any of the discovery preclinical work, I would encourage you to do so by searching for amnion epithelial cells, and you will find most of those studies are from the Monash group. The discovery to trial journey, as you can imagine, was a very difficult journey. It took us close to 10 years to get it into the clinic. We were brave enough to take it to babies first time, so this is first in human. No 15-year-old, 17-year-old, 25-year-old university students were given these cells. The first cells we gave were to sick babies. So you can understand the nervousness with which this was taken, but obviously we had very good support from our clinical colleagues and our ethics committees, and we also obviously had worldwide experts fielding into this. The process of making cells is very easy. You can Google and you can easily make the cells yourself. It's basically digesting amnion itself. But when you have to make these cells to give it to babies, to trial patients, it had to be done in a certified GMP facility. The picture on the bottom is an example of a biospherics isolator unit which is able to manufacture these cells, which we have on site at Monash. So this is Flynn. He's our poster boy for the study. Last year we published our early experience of these cells. So we published the experience till discharge of these babies from the NICU. Like I said, these are severe bronchopulmonary dysplasia kids. So we recruited 6 infants. 3 of them had severe bronchopulmonary dysplasia by any definition because they were in respiratory support at 36 weeks of postmenstrual age. So you take any definition, they would be severe bronchopulmonary dysplasia. But not only were they on respiratory support, the first 3 infants were intubated. So just try to think back in your unit, how many babies after 36 weeks who were born at extreme prematurity are still intubated. So it took us almost a year to recruit our first 3 babies who were intubated, and then it took us another 6 months to recruit our 3 babies who were on CPAP after 36 weeks of postmenstrual age. So you can see the median time of delivery of these cells was close to 3 months of age, and it was anywhere between 2 to 6 months of age. Our first baby was almost 6 months before we could give those cells, because we don't have intubated babies at 36 weeks postmenstrual age easily. The cells were given at a very low dose, 1 million per kilo. Our intention for the study was just to show safety of delivery of these cells. These are digested cells. They are not cultured or harvested. They are digested cells, and we were worried about the size of these cells. They are bigger than mesenchymal stromal cells, and that's why we chose to give it via the intravenous route. I would encourage people to read this publication for details of the early outcomes. Today I'm going to focus on the follow-up outcomes. So this is Harry, another poster boy of our study, where basically we looked at their outcomes over 2 years, and we did a number of investigations, except clinical review every 6 months. We also had ultrasound of their head when available, that was early period, then ultrasound of their abdomen, MRI at 2 years, also neurodevelopmental outcomes, and cardiac and X-ray, cardiac echo measurements and X-ray of their chest. So coming to the outcomes of the study, this slide focuses on the cardiorespiratory outcomes. This is an X-ray of one of our babies, and you can see that they had typical changes of bronchopulmonary dysplasia right up to the time they were 2 years age. There was one hospitalization on a median across these babies in the first 2 years of life. The burden of BPD in the severe burden of readmission to the hospital or ICU is quite high in these babies, but in this case we did not see any ICU admissions, but on an average we saw one hospitalization per patient over the 2-year period. They were very severe BPD kids, like I said. On a median, they stayed in home oxygen for 2 years of age. Okay, the earliest anyone got off oxygen in this cohort was 10 months. We did not have a control group. The idea was not to show that this has got efficacy. It was only a safety study. And at 36 weeks, if you were to have a control group, I would have taken another 2 years to recruit the control group infants as well. So we are doing a dose escalation study, which I'll come to at a later part, where we are trying to find a signal of efficacy, but right now it is all about safety. As expected, many of these babies had reactive airway disease or the precursor of asthma. 2 of them had pulmonary hypertension, and 1 of them had systemic hypertension as well. The ultrasound and the MRI shows an example of a baby with prominent ventricles and loss of white matter, although mild by most scoring methods. 3 of these babies who had severe BPD had developmental delay. 2 of them had the startup of behavioral disorders starting to happen, and 1 of them had hemiplegic cerebral palsy of a mild variety on GMFCS. All 5 of them had hearing loss, and you can imagine they were on intensive institutionalized medicine for a long period of time, 3 of them requiring hearing aids. 3 of them had growth issues. There was need for gastrostomy feeding in 2 of these babies. 2 of them also had coincidental hypospadia, so they had more surgery. Most importantly for us, these were cells given to humans for the first time, tumors. There were no tumors. We got a scare in one of the babies when we found reactive nodes near the aorta in the abdominal scan. 4 months later, we repeated the scans and tumor bloods, and there was resolution of that. We consulted an oncologist, we consulted a radiologist, and all of them felt the echogenic signal from them wasn't suggestive of tumor. So that was reassuring. We have not had any further indication of tumor in this baby, and he's constantly being followed up. So where are we up to with amnion cells for BPD? So our safety study, like I said, was published last year. This study is currently in press in Stem Cells Translation Medicines, should be out in a couple of months. And our dose escalation study protocol was published earlier this year in BMJ Open, and we hope to start our efficacy study in 2 years' time when the dose escalation arm of it will be finished. I'd like to thank all my colleagues at the Hudson and Monash University. This is our core team with our first recruit, Caden, when he was around 2.5 years of age. And to finish off, I would just leave you with this slide to ponder over, where Liz Baker, one of our PhD students, is currently running the dose escalation study, which shows that we are going to go from a dose of 1 million cells per kilo to 30 million cells per kilo. So it's a slow dose escalation. We are in phase 2 of the dose escalation right now, and hopefully by the end of next year, we would have finished this study, which would show us a signal of efficacy. These babies are being given these cells at 2 weeks of life with a predictive model for BPD. Thank you very much for your attention.
This paper is open for discussion, and while people are coming forward, if you find us the cure for BPD, then in no time you're going to be professor, so I'm going to call you professor.
Thank you.
I have a question for you. I attended a talk this morning about stem cell therapy by Professor Kramer from Maastricht. And he was telling us that we have a long way to go before we can start treating infants with this therapy. But he was mainly talking about mesenchymal stem cells. Why do you think that your amnion cells are superior to mesenchymal?
So we are not trying to show superiority, and ideally we would like to have a head-to-head battle at one stage, but I think both cells are at an early stage of experimentation. The mesenchymal stromal cells, like I mentioned in the morning, are cultured cells. So they are taken from fetal or adult tissue and cultured and then exposed to various, obviously, you can say interventions to then deliver. Amnion epithelial cells are, like I said, as easy as this. You Google amnion epithelial cells and this is how you make it. Find the placenta, cut the amnion, digest it, mince it, centrifuge it, count it and give it. So they are easily available. They obviously will go through, like I said, the rigor of delivery, but they are not altered in any sense of the word. They are not immunogenic. They've got no properties which should give them any signal of problems, whether from the processing process or from the delivery process. In terms of, I'm not saying they are better than mesenchymal stromal cells, but we believe that they are a cell which are readily available, ready to use, which should be looked at.
So, Atul, I'm wondering if you defined any adverse outcomes a priori before you started the follow-up that you were particularly concerned about for this, because it's difficult without a control group to know if there's any change. Yeah. And secondly, although I appreciate you didn't have a control group for this, do you have any way to match the outcomes against some kind of case control historical outcomes so that you can ascertain whether these are approximately the same or increased or decreased?
Excellent question, Jane. As you know, the Korean group had a historical control for their patients. Their patients were given the mesenchymal stromal cells within the first 2 weeks of life. I've been in NICU for 15 years. A ventilated baby at 36 weeks is once in 2 years generally, so there's no way I can match them. I can try to match them, but I'll have to go back 10 years to find 3 babies who are ventilated. We had a priori definitions of our adverse events, so any feature of abnormality seen on imaging or clinical review was an adverse event. We had obviously brought up this as an adverse event when we found that nodes in the abdomen, but informed our data safety monitoring board who were carefully monitoring each step. We were informing our ethics committee after delivery of cells to each of the patients, but also after each time point of follow-up, so 6 months, 12 months, 18 months and 24 months. We would have loved to have a historical control, but like I said, I think I would be dealing with babies in a different era with different ventilation modalities.
So in the absence of any other questions, thank you very much for your presentation.
If I've got 1 minute, I might show the mechanisms of action because nobody's asked that. So the mechanisms of action of amnion epithelial cells are paracrine, like the mechanisms of action in mesenchymal stromal cells. So you might be wondering how do they work. They have a very complex mechanism, and I was not going to go through this, but just for your information, if you are interested on how these cells work, they are not very different to mesenchymal stromal cells. They activate, they are like Sherpas, you know, one of my scientists says, they are like Sherpas who help you climb Everest. They are going to help garner your immune system in the body to help fight the inflammation and process happening with BPD. Thank you very much.
Thank you, Atul.